Welcome to this community talk of June. This community talk is dedicated to the research project on improving health of school children with a new community-based intervention, the Tanzania Experience. We would like to welcome Dr. Geoffrey Makenga of the University of Antwerp and the National Institute for Medical Research in Tanzania. Also, warm welcome to Professor Jean-Pierre van Geertruiden of the University of Antwerp and Dr. Abdullah Lusasi, who is connected at the Ministry of Health of Tanzania. Allow me to make 3 practical announcements before digging in. Throughout the presentation, you can raise your questions in the chat. I will make sure to discuss them during the Q&A. During the presentation, please mute yourself. However, during the Q&A itself, you can unmute yourself and put your camera on to direct your question to the presenters. And finally, the community talk is being recorded, so we can share it afterwards on our YouTube channel. So be aware that you're being recorded. Voila, without further ado, let's start, and we hope you enjoyed this community talk.
Okay, next slide. Good morning, everybody. Thanks for joining this community talk. Today, our topic is school children, who are very important for disease control in general. And I hope you will be convinced after this talk that also for malaria control, school children are very important. Next. So when we talk about malaria, most of the time we think about with reason, young children and infants that die, that are risk groups. Also pregnant women at a higher risk compared to other adults. And also people with HIV, which are immune suppressed, or international travelers, especially coming from non-endemic areas, are at risk. However, next. We asked ourselves the question, what about school children? Next. Indeed, of course, when in healthcare, we always look at the need. And here you see, these are data coming from a demographic health surveillance site in Kenya, where they measure malaria throughout the years. And you see that indeed, clinical malaria is mainly in under 5. Next. But when malaria decreases, what do you see? That in fact, the children, school-age children, have an increased risk that you get a shift from children under 5 to school children who get more malaria. And so both groups, 12% of the children get malaria during the year. But if you look, and the expression is in Africa is the hippopotam, the hypo. So what we don't realize, and in fact, school children were the biggest burden of the reservoir of the malaria parasites. Next. So what you see is that in fact, about 50% of the children harbor parasites in the blood without being sick, which is almost double as on children under 5. Next. Now, if you take into account the demographics from sub-Saharan Africa, and you look at the burden of disease and the asymptomatic carriers, you easily get that in fact about 40% of the reservoir and 40% of the burden lies in school children. What is the impact on transmission in the population? We don't know. We approximately think it's also about 40, but that has to be. But this is fresh from the press. This came out last month in the Nature, one of the most important journals in the world. And they have shown that, in fact, school children are 6 times higher transmission risk than other populations in the population. So most probably this 40% of transmission, so 40% of the reservoir represents a much higher even risk of transmission of malaria in the community. Next. What are the consequences? So malaria, of course, the clinical malaria, school children get less sick than children under 5. However, if they got sick, up to 50% of the children that die in school, in primary school, are from malaria. And for the asymptomatic children, the problem is indirect. In fact, they have almost 5 times higher risk to have anemia, which at this turn has a problem for school performance through different pathways. Absenteeism because they are sick, not concentrated in school, reduced attention, etc. Next. What can we do about it? First of all, secondly, we can, yeah, next. Next, we can give, there are now vaccines, but they are very expensive compared to bed nets and have some the same vaccine, and they start to roll out. But we can also do chemo prevention or screen the people and treat or give supplements. Now, like iron or folic acid. Now, for the bed nets, we know that bed nets are very, very efficacious to reduce malaria. That's the most efficacious tool we can have at the level of community. But there's a problem here. Here you see a graph, and where you see that both in boys and girls, that school-age children don't use bed nets. And that bed nets it's the only target group of the whole population that in fact where bed nets are not so efficient. A second, however, is that, of course, school children are a very good vehicle to distribute bed nets. So if you want to, in a cost-effective way, get the whole population delivered bed nets, then in fact, school children are a very good pathway to distribute, but they themselves don't use the bed nets. What next? Of course, health education for any disease is important, and also for malaria. It's very important that children learn at school what is malaria, how it's, and so that they recognize it and fast get treatment. I come back to this later. Another option could be that you start screening all children and that you treat those that are positive. The problem is that's very costly approach and not very invasive. Children don't like that. If they know that the team will come to check them, they maybe pretend they are sick. Another possibility is that we do chemoprophylaxis. This is a lot done in travelers with Lariam or with Malaron, where you give treatment permanent to the people, and then they are protected against malaria. The problem is that is not recommended for people living in endemic areas because it enhances drug resistance, the immunity is development, and there's a problem with adherence, which gives drug resistance and very costly. There is, however, another strategy which has been invented in the last decades, and that's intermittent preventive treatment. What is intermittent preventive treatment? Is that you really give a curative dose of antimalarials at fixed time moments at the people, regardless if they are infected or not. Compared to chemoprophylaxis, this reduces all the risk and all the problems of chemoprophylaxis. And we have at the moment 2 examples that are recommended by the WHO, and that's the IPT in pregnancy, where they, during the antenatal consultations, give the pregnant woman a preventive treatment, or in infants during vaccination, the EPI or PEF in French. We thought, and we not alone, other researchers say, wait a moment, can we not do intermittent preventive treatment in school children? And we use the NTD, the neglected diseases, mass drug administration model for worms and schistosomiasis that's already going on for decades in Africa. And then you follow the local epidemiology and the school agenda to see what is the different parameters. And there have been several studies done globally. Before we will now present our studies in the next, but before we did our study, we did a review of the literature. But I give you here an updated, a more recent systematic review that was published in the Lancet, where you see that IPT prevents at least 54% of the infection, reduces anemia in school children by 15%, reduces by 50%. Half of the children don't get less sick during the year because, and this is not significant, but indicative, is that for 88% protection against low test scores. So for this, I give you now the floor to Geoffrey Makanga to show what we've done in Tanzania.
So thank you very much, JP and others. So I will talk about the effectiveness and safety of the intermittent preventive treatment of malaria with the hydroartemisinin piperaquine, which is an antimalarial drug given to school children with aim of reducing malaria related. So next slide, sorry. So here is the map of Africa and it shows where Tanzania is. So it will, the talk will present on the experience from a clinical trial that we conducted in Muheza district, and then followed by an implementation research, which is a pilot by the Ministry of Health, which covered 3 districts, Handeni, Town Council, and the District Council, as well as the Kilindi District. And then later on the policy and practice that emanated from these studies. Next. So the situation in Tanzania, as you have seen on the background that given by JP, here is the stratification of malaria in Tanzania. You see in areas that are red, these are highly endemic. And in the northeast of Tanzania, that's where Tanga is. That's where we conducted our studies. Next slide. So if you dissect and see who are most affected here, you find most of the malaria cases which present as asymptomatic are from the school age children between 5 and 14 years. Next. And this also doesn't vary with the seasonality. For the under 5, it varies with seasonality. But for 5 to 14 years, these are school age children, you see it is still high despite of the low season. So next slide. And this is the same also for other districts in Tanzania, those which were red high endemic, you still find the school age children are highly affected. Next slide. So what we did in Tanzania, next slide. We started with a small clinical trial covering 7 schools, but it initially started with a gathering between the 3 ministries, the Ministry of Education, Ministry of Health, as well as the local governance. So here we collaborated with those people from the dealing with school health, and this was supported by Veritas from the University of Antwerp. And it came up with a discussion on the comprehensive school health policy for the programs in Tanzania. So next slide. So in this slide, I will show you the design of the clinical trial. Next slide, next. It started with 7 schools, and the children in these 7 schools were individually randomized to either of the 3 groups. One is receiving antimalarial called dihydroartemisinin piperaquine, DP, and the other could receive another antimalarial called artemisinin amodiaquine, or ASAC, and the other one would not receive any treatment. It was called control. And this one was a study conducted over 20 months to almost 2 years. Next. So we recruited those children around 1,000, 1,500. Those were the ones that were randomized to receive all these in 3 different arms. And in the first year, we gave them the intervention. As you can see, they were given the intervention according to their location, 4 months apart. And next. In the next year, we didn't give them any intervention, so we just followed them up to see if there is any rebound. In all this time, we were collecting blood smear for malaria testing, which was at the baseline, as well as at 1 year later, as well as 1 year later. So which means we collected blood smear for malaria 3 times in those 20 months, but we regularly collected to see anemia measures by hemoglobin levels. So these were conducted, and you can see that we analyzed based on the intention to treat, as well as per protocol involving those who had completed the doses and have completed all the visits that were assigned. Next. So this is how we did during the recruitment. We usually started with the sensitization to the communities, with the school teachers, as well as the school parents committee next. And there also, after getting consent from those parents, we entered into the schools for testing and also other examinations next. So we also, apart from malaria, we also tested for cognitive levels. So here on the left is a test for cognitive test, and on the right is the psychomotor assessment, which was a shuttle run test. As you can see, the children running, and they are getting tested. And then after that, we also conducted IPT, which is the giving drugs to the children asymptomatic, all those were in those randomized in those schools. So they were dispensed using the school teachers in collaboration with the community health workers, and later on they got lunch. Next slide. So the findings from this particular clinical trial, you can see next. It was published already in Lancet. You can see in this particular first graph on top left, you can see the malaria prevalence dropped very effectively, significantly on the groups that were receiving intervention. And on the group that was not receiving intervention, the control, you can see there is a rise in malaria prevalence there. But on the second year, when we didn't give any medication, you can see prevalence coming back to where it was before. It's not a rebound, but it was just coming back to where it was. Next. So this below is a figure that was showing the effect on hemoglobin levels. So you can see this the first year when we gave the intervention, you can see in those groups that received intervention, there were increasing hemoglobin levels compared to those which didn't receive any intervention. And you can see these changes is significantly impacted by the intervention rather than the routine. As you can see on the second year, where we didn't give any medication, you find all the three groups are behaving normally. There was no any rise in hemoglobin level. Next. So from this study, we learned that the intermittent preventive treatment of malaria with the to school-age children was able to reduce malaria. You can see the protective efficacy was up to 70% using DP, as well as 68% for using the other drug, artesunate-amodiaquine. Next, it was also significant in terms of reducing anemia, as you can see here, up to 34% for the drug ASAC. Next. So also we estimated in terms of the clinical cases, you can see there was a decline in number of episodes of malaria for those who were in the intervention group compared to those who were in the control. Next, with the next again. So you can see here down there, you can see the same graph. When we didn't give any intervention, there was no change. So meaning that only the intervention was the one that reducing the number of episodes. And the protective efficacy, you can see, was 20% for DP, as well as 19 for the ASAC. And the number needed to treat there was 5 or 4 for decreasing the parasitemia, but up to 40 for those if you aim at clinical malaria. And in terms of the impact on cognitive and psychomotor effect, it was not that much significant, although there was a significant rise in hemoglobin level. I mean, it was associated with the increase in, the rise in the hemoglobin level was associated with the psychomotor scores, but it was general in terms of the cognitive impact. It was not significant. Of course, it could be because we didn't aim our power to this measure of cognitive and psychomotor function. Next. So we learned from Muheza study that both drug and malaria were safe and effective in reducing malaria thalassemia, as well as it was also feasible to use the school teachers, and that we could see that it was also impactful on anemia. And we also saw that IPTC, if you intend to implement it, you should be continuous, because 1 year alone is not enough. You have to continue to be able to reduce or to shrink the reservoir, as we have explained. Next. So from this study, we get together with the National Malaria Control Program in Tanzania. That also updated the guideline in 2020, which also included the implementation of IPTC in the selected districts. And there they had already selected the drug, dihydroartemisinin piperaquine. So next slide. So we conducted this implementation research in collaboration with the control program, as well as the local government, and this was funded by the Global Fund in Tanzania. Next. So how we did here, different from the clinical trial, we regarded on the seasonality. So we looked onto the 3 districts, and we looked onto the data on malaria, as well as rainfalls and when exactly are the peak. So we chose to give the drug at the moment that there is about to be a peak of malaria, so that we can give the drug to children that can be able to protect them during that particular peak. And when the drug wanes, because we saw from the clinical trial, the drug would stay for almost 64 days. So which means those 64 days were maximally applied to the point where malaria cases would be rising. So on our assessment, we saw that months of March, August, and November were the feasible ones to reduce the malaria cases. Next. So how we did this, we did it as a cluster randomized trial and an implementation effectiveness hybrid design. So in the next slide, so we randomize in each district, there are wards. So we randomize, for example, taking example of Handeni district, we randomize into 2 halves. One was receiving the drug, DP, and the other one was a control. So all students in the 10 wards were getting the intervention, and all students in the control didn't receive intervention. And then later, we selected at random 5 of the 10 wards in each groups. We led them for monitoring. And next. So you can see there, we did the same also for the other 2 districts, and then in Kilindi, where we could combine them because they had the same instance. So we randomized them together, and we could see also the same, half of them could receive intervention and half couldn't. And there we also selected half for receiving them, being monitored closely, and both in DP and as well as in control, just to measure the effectiveness side. And from these wards that have been selected for monitoring, we chose only 1 school at random. So a total of 24 schools were selected from the 24 wards, and about 4,000 children were chosen to be enrolled for monitoring. So, however, the intervention or implementation covers in all these districts and covers all children in these particular wards, regardless of whether one was chosen for monitoring or not. So all these children in that particular school received the intervention from class 1 to class 7. Next. So here you can see that how the randomization went. You can see the intervention wards are those in green, and the control wards are those in red. Next. So here, because it's a program level implementation, we involved the stakeholders from the national level to the district, where you have to get to the security council, dealing with also health at the district level. So in both districts, we were able to conduct these meetings for engagement, also getting them involved into the process of implementation. Next. So this is also another for community engagement in local government, going down to the level of the wards as well as the districts, the villages, school committees, and eventually to the school children themselves. Next. Excuse me. Next. Yeah. So this is the school committee meeting, the village leaders. Next. This is also a training, because we are now covering a huge area, so we had to train trainers to help us train those teachers in those particular areas. So we had several meetings to train. These are the children, I mean the trainers that we trained, and then they went to train teachers at each particular ward. We also involved the Tanzania Medicines and Drug Authority for pharmacovigilance aspect, so that they could be able to assess any safety issues that would occur. Next. So on the implementation aspect, you can see we were able to cover almost 127 primary schools next, with over 73,000 pupils which were reached. And all these were administered drug on dot, which is a daily direct observed therapy. And it was given through teachers, as you can see on that picture. And you can see in each round, there was an increase in number of students that have been getting the drugs. And of course, the drug also is the way they've used it has been much more efficient. As you can see in the last round, there was fewer lost drugs or lost tablets based on the implementation. So this figure shows you the coverage that we had. So you can see over, for example, for Anden district, the coverage was 80%, 81, and then up to 85 on the last round, which also gives you a picture that the intervention was very acceptable by the communities, but also by the teachers themselves. And you can see very few refusals in on all those parts. And the overall, you can see on the last part of this graph that in overall we were able to get 80% coverage in all these 3 districts. And the next, these coverages were also inconsistent with the school attendance in those particular areas. So next. So now we go to the second part, which we measured the effectiveness, which is just targeted those children which we had selected for continued follow-up. Next. So in this next, we followed those 24 schools, as you can see, and we gave them the medication in 3 rounds, almost 4 months apart, but based on the seasonality as well as the school curriculum. Next, and then on the last, we just went there for assessment for our endpoints. So here you can see the impact of the intervention on malaria prevalence reduction, as well as in HB or hemoglobin change from baseline. So you can see malaria prevalence was significantly reduced on those intervention arms, as well as for the, if you compare to the control didn't have significant change in malaria prevalence. Next. So if you analyze this based on difference from these clusters, you find that we were able to reduce, IPTSC was able to reduce up to 80%, 81% of the malaria prevalence in those school children. But if you stratify based on the strata, because the WHO has recommended IPTSC to areas where prevalence is more than 10%. So if you look that as strata, then you can find the prevalence is really indeed high in those areas with high strata, 81.2%. And those which are lower strata, they are also having 58%, which was not significant, but still we have to also look later on how we can be able to target these areas in the low area. Next. So in terms of clinical malaria, next. And next. So you can see here that when we were giving the drug, malaria episodes were significantly reduced in the intervention arms compared to those in the control. And you can see the impact was even high on high strata, where the protective effect on clinical malaria was 54%, and compared to 11 in low strata. of course, the overall prevalence, I mean, protective effect on clinical malaria was 41%. It was significant. So these results are consistent consistent with the systematic review also was explained before by Professor JP. And next, we still see that we need to implement this, but once we implement, we have to continue following up, that we should not stop just in 1 year, but continue for the next year, probably for the consecutive 3 or 4 years, to be sure that the impact is becoming more noticeable. Next. So in conclusion, the implementation was feasible and was very well acceptable to the communities. Here I could also mention that the school teachers collaborated well with the parents who would be there to actually help them on cooking, as well as and IPTC is currently recommended by the WHO since 2023. And implementation now will now need to go in hand with monitoring of course, drug resistance markers through ongoing school malaria parasitological surveys that are indeed being done here in Tanzania. So there is also work in progress on health economics and population impact, and also mobilizing the resources for scaling up of the third of the country and the impact on molecular epidemiology. Next. So here is the policy brief that was developed following the implementation and the piloting. Next. You can also see in the policy brief that we have recommended the strategy be administered at regular intervals as complementary to control strategy, but also IPTC delivery schedule should mimic malaria seasonality, as we have seen in the pilot that we have conducted, and there should be continuous monitoring of drug safety, malaria prevalence trend, as well as markers of drug resistances. And for equity reason, there are children who are not enrolled at schools, or those which are enrolled but not attending. So there should be also an involvement with the social welfare department so that they can be able to be also targeted in this intervention. Next. So here I leave my colleague, Dr. Abdallah Rusasi from the National Malaria Control Program, who will tell us about what went on the government side on the implementation of IPTC. Welcome, Rusasi.
Yeah, thank you so much, Makenga and team. I'm Dr. Abdallah Rusasi from National Malaria Control Program, Tanzania. I'm the head of case management. So I'll take you through the strategic objective of the National Malaria Strategy Plan of 2021-2025. The strategy plan is to prevent the occurrence of mortality related to malaria infection through universal access to appropriate diagnosis, treatment, and the targeted provision of preventive therapies for vulnerable groups. And then the guideline now include IPT school as a strategic preventive strategy recommended to moderate and high endemic strata. The IPT school is one of the strategy approach for malaria burden infection. Can you continue, proceed? Yes, malaria chemo prevention. This is IPT school. The intermittent preventive therapy in school children IPT school was attributed to 80% reduction in malaria parasitemia in operational research. Result done by NIMRI in 2021. In GC7, the program requested funding to implement the IPT school in 4 council, which again will be prioritized according to the selection will be prioritized according to the final results of a school malaria parasitology survey of 2023. The program has selected DP medicine for IPT school, and they will start implementing in 2024 at Kibondo, and 2025 for the rest of the 3 district council. Thank you. The IPT school implementation in the priority area. In 2020, as Makenga said, we had implemented in 2 regions, the Western region, Kigoma, and then the Eastern region. where the NUMRI has been conducted is Sitanga. So the Handeni, TCDC, and the Kilindi through NIMRI, I was said before. And then now we expanded the area according to the new stratification of 2022. Now we have a lot of area. Actually, we have 57 council, which are eligible to be conducted with the IPT school. Okay. The country has been introduced the integrated coordinated CHLW program, where now we mapped the area whereby the CHLW will be deployed in this area. So now in our side, in IPT school, we have now opportunity to scale up or to improve the coverage to school, to improve the coverage of IPT school implementation in the country by using these CHLW, which are going to be deployed across the country. Okay. Thank you.
Okay, next slide.
Wait. Yes.
Yes, so thank you. So now, while this is rolling out in Tanzania, what still has to be done? Of course, the scaling up in Rwanda to 1/3 of the country will lead to a lot of new, enrich the database that we have already from all the studies that have been done and the study in Tanzania. You have more data and power to all the indirect benefits, educational absenteeism, because there in the studies are not, you have to do it at country level to see these benefits to become significant. However, the tendency is clear. What is maybe underestimated is the health education. One of the strategies, of course, to control this disease, to educate people. And what we probably underestimate, if we implement IPTSC and malaria drugs are given by school teachers and not by a nurse or a doctor, it has an enormous impact on the children, because if their teacher, their God, who learns them to read and to write and learns geographic and history, distributes malaria drugs to them on a regular basis, then it has an enormous impact on the knowledge of the children of malaria. Also, the transmission, which probably is very high due to the school via the school children, we will be in real life be able to measure this, and the indirect impact on the burden in children under 5, and which may be higher than the impact on the overall building. Also, there may other things pop up in other districts, operational and policy challenges that may feed into the policy brief that has been made based on our first experience in the area of 120,000 children. And then we have some desk work. Of course, there's a paper came out on the resistance of the drug markers, which showed that in fact the drug pressure is not there for getting drug. If you do it, you have good coverage. The immunity, also a paper will come out, and with modeling, we will already try to predict the impact on that population level. On another hand, we will we will also look if the schools cannot be used as a sentinel instead of doing surveys, expensive surveys at community level. Now, and last but not least, there's an international group setting up under the leadership of Liverpool School to standardize it with the parameters to follow. And last but not least, we think malaria is important in school children, but there are a lot of things important, and we could use this whole program as a stepstone to develop a real school health program. There is the oral health, there's the vision health, there is the boost of immunization in school children because they get their vaccines as a baby, but they need a boost, and that's not done in most countries. Deworming, the nutritional health education. So a lot of health education could step into this to develop a full-blown, this could be an opportunity. And that was the final of our talk. Thank you very much for listening to all. We thank, of course, all the participants, the National Malaria Control Program, NIMRE, the funders, VLIROS, of course, and also for VLIROS for hosting this talk, and also the implementers, the funders of the implementation, the Global Fund. Thank you all.
Thank you for this presentation. We always preach that what is key for us and stands out compared to other funding agencies is that we want research results to be translated into practice and policies. And I think this is a really nice example of how this can look like, how this can take shape. So thank you so much for sharing your project and your experience. We would like to open the floor for questions from the audience. So if someone has a question, please unmute yourself, raise your hand, and feel free to direct your question to the presenters. In meanwhile, I see also we had questions from the chat, but I propose someone takes the floor. And in meanwhile, I will have a look at the question.
I can give an hello. Can I we give an answer by chat or online?
You can do it online, maybe for everyone to.
So there was. So there is a question that comes from the recent regards to, is there published showing its impact on community for transmission? So the problem is to measure transmission, then you need to scale up what's happening now in Tanzania. So there are two ways to measure transmission, is to do or modeling, but that's desk work, that's high level statistics and ICT. And the second option is when you roll out, which is now happening in Tanzania, to look at the real impact of the IPTSC on the overall transmission impact. This is the only way forward, but the direct impact is so high that there's no, in fact, I would say no choice, that's the wrong word, but that if it's so obvious that we should implement it, but all the indirect benefits like the impact on the overall burden of transmission is also very interesting, of course, because if it reduces also malaria in younger children and in the rest of the population, then we have additional benefits. Over.
Okay, thank you. And I see indeed Geoffrey also answered some questions by chat already. I saw one question saying this is a very interesting research project. Are there any plans or is there any possibility to roll it out in other countries?
Yeah, I think there is that possibility. I've seen that spirit rising, especially in the last meme conference, which was held in Rwanda. I saw a lot of national malaria control programs from sub-Saharan Africa. They are coming up to see how they can be able to implement such intervention. So we have already been approached by some, and we have provided them with the technical inputs on how they can be able to roll it out. So we are continuing, and we are happy to support them in case they come again. Thanks.
Thank you. If someone has a question, they put it in the chat, but they want to direct it to the presenters, feel free. I might have a question myself, actually. So at the end, your colleague talked about how it was rolled out by the Ministry of Health, but how was the government involved in the project? Was the government involved from the beginning? Were they involved at a later stage? Was it easy to involve them? Were there some challenges?
Yeah, thanks. So getting from the first slide there where I showed you how it started, there were 3 ministries that were involved when we just were designing on the clinical trial. So from there, the National Malaria Control Program was also involved there, was part of the team. And they were able to understand what his NIMRI is doing. And later on, when we were conducting our clinical trial, by the time we were starting to complete it, that's when they brought up us with another request that we could pilot it in 3 districts as we have done. So they were there, and it is the government of Tanzania, through the funds from the Global Fund, that supported the pilot on the implementation. So during the supervision, the National Malaria Control Program participated ministry on the supervision, as well as making sure that all things are followed, and they are part and parcel in all the process. I think Rusasi can testify on that. So, however, of course, we acknowledge the involvement actually from the Belgian government, from the starting up as a seat into the clinical trial that also resulted into this bigger involvement from the government as well. JP, you want to add?
I can, well done, Geoffrey. I think it's a very important message. If you have such interventions which are interdisciplinary, involving different ministries, it's very important to involve them upfront like we've done. I know in other countries, they try to implement IPTSC and everybody's willing to do it. But at the end, you have then problems of communication or articulation between ministries and who does what, and that who can plan it in. So it's very important to upfront involve all the ministries to get everybody ownership from the start. And that workshop in 2017 was very important in this regard. Also, the implementation was done completely by the MOH, not by the researchers as such. We were there to notify everything, to document everything, to show you what you've seen today. But in fact, it is the Ministry of Health who took the lead in, so who did the implementation. The first study we were in charge. Aide Nimre was in charge, National Institute for Medical Research. But in fact, for the second study, the MOH was the implementer.
Okay,
but it's a very important, it's the most of the time, implementation is the biggest hurdle sometimes. The evidence is one thing. Now, there's also for other countries want to implement it because it's now recommended for WHO, which is a very important prerequisite for a lot of countries. There are not a lot of countries who dare to implement something if it's not recommended. So it's recommended now, but there's always an inertia. The problem is that you need budgets, and budgets are made upfront. So in 2024, you make budgets for 25 and 26. And so if IPTSC is not part of the budget line, then there is sometimes it takes time then to implement because it's an investment, in fact, because you budget IPTSC, you have to put that in the budget, and then it's only at the end of the year that you see that you saved a lot of money because the children were less sick and that they didn't go to the clinic and that they didn't spend money for drugs and that they were not absent at school. So your gain is after the investment, and so there's an inertia in the system always for preventive programs. Over.
Okay, thank you. I see there is a hand being raised. Ole Skovmans, please go ahead.
Yes, it's a repeated question I put in the chat. So is this program, when it becomes rolled out, financed by the Minister of Health or by donors?
Malaria control, I've put it already in the chat. Malaria control in Tanzania is together with HIV and TB financed by the Global Fund through the Ministry of Health. So the Ministry of Health is implementing with own funds, but with international funds from the Global Fund.
Yes, but this comes from their, this comes from their research fund. That's not the same. If it has to be ongoing program, it has to be...
No, the implementation research that we have shown today was paid by the Global Fund, so by money they earmarked from the implementation. So from the routine funds for Tanzania, a small part has been used to finance this operational research.
Yes, but that still means there's no guarantee that they will finance an implementation on national level.
Yeah,
yes, Geoffrey.
Yes, so Rusasi is there. He can testify that we have received in the current year scheme of global funds support to NMCP for 3 years, the coming 3 years. The 3 districts which have been piloted will continue, 4 districts will continue with the implementation. So while those will continue, government is still looking for other support that if in case others come and they support other districts, that are very welcome. But at least we have some 4 which will be ongoing and will be continuing to show the testimony to others. Thanks. Musasi, if you have something.
Yeah, thank you so much, Prof. and Makenga, for very good clarifications. But I also concur with you that the ministry has been well involved and participated from beginning the clinical trial, the pilot, and now we are sharing the policy brief or strategies. Again, through this one, we shared with the Global Fund during GC7 funding request, and the team, the Global Fund, has responded what has been done in Tanzania, and we received some money, some fund to conduct the IPT school in 4 councils. And then now again, the door is open to the stakeholders to come and assisting us to implement another area. We have a very big area to implement IPT school. 157 council. It is in a high risk area where the IPT school can be implemented. Thank you so much, and you are welcome.
Thank you very much. I would like to give the floor to Mohamed Sani, who also raised his hand before. I think he's still there.
Okay.
But maybe his audio. We can't hear you very well. Okay, I think now it's
Can you hear me?
Yes, please go ahead.
Good morning. All right, thank you very much. I'm actually wanted to ask a question about the.
Oh, so sorry, we cannot hear you
plan.
very well though.
Okay. I mean, how can we implement this measure this how can we control the transmission of malaria in areas like the urban areas where we have a lot of clustering of people? Like, how can we effectively carry out the rollout plan in area like in the country like Nigeria, where we have a lot population? How can the implementation be carried out effectively? I don't know if you can share some views about that.
I don't know if you heard the question very well. I think it's the same as the one you put in the chat. So let me maybe repeat.
Yes, I heard it. The
okay,
question was how it could be implemented in Nigeria. I think we leave the honor to the National Malaria Control Program, to Nigeria, of course. They know the endemicity in their countries and also the drug resistance in their country. So they for choosing the molecules, and they also know the malaria seasons. So you have to take into account the malaria seasons, which drugs can be used, and also how the schools are, when are the holidays and things like that. So bringing this all together, then there could be the choices can be made in which districts this could be implemented. That's one aspect, but that's a bit theoretically. Now for the practical rollout, I think there the experience of Tanzania will be shared and should be shared, that you could see how they've done this. So by implementing it first in 2-3 districts, each country has its own particularities, and not every country is different. So I think I would suggest to do the same as Tanzania. After you made the exercise and made a principal decision, that you then choose 2 or 3 pilot districts to work it out, to see how you're going to do it, to work together with the schools, how you're going to follow it up, and to work it out following the example of Tanzania, to do it in a couple of districts and then adapt it to your country context and to how your country is organized, for drug distribution, for monitoring, etc. And after that, 1 or 2 years later, with that experience, you can make a very nice Nigeria updated policy for Nigeria, and that's over.
Yep, I can add that to Mohammed.
Thank you very much.
Mohammed, I think we also had a talk with the National Malaria Control Program in Nigeria, sometimes in last year, end of last year, I think. So we also shared with them the protocol, the tools that we used in Tanzania. I think they are somehow going far to be able to implement. So if you follow with them, then they can give you the updates on where they are now. Thanks.
Thank you very much. I really appreciate the answer.
If I can add one thing, is we should avoid to do further trials, because I think the evidence is clear with all, because otherwise every country starts doing a trial. I think the country should start with implementing it in 1 or 2 districts, pilot districts, really operational, to see their challenges and to see how it works. A trial as such, I think, is more technical and is not needed anymore with all the evidence that has been gathered in at least 6-7 countries in Africa now, in different settings, in different over.
Okay,
All right,
thank
thank
you
you,
very
sir.
much. I think we have room for one last question. Fasiatu Fairu, please go ahead. I hope I pronounced it somehow correctly.
Thanks for the presenter. My question is, for how long the IPTSC should be continue to clean the reservoir, and also have a team plan to follow this child for a rebound effect after the stopping of the IPTSC. Thank you.
Yeah, thanks. I can start and JP will follow. So
Yeah, start.
The idea is, if you conduct in the first line, I mean the first year, for example, you find there was a huge reduction that you can do. But if you continue, we propose that you can continue based on the data and modeling aspects, which can take you up to 5 years in some settings, in some areas. And by then you can be able to assess whether this should be continued or not. But I think the better thing is to continue and continue, monitoring on those parameters, as you can do a stratification that is being regularly updated. So once you do that, then you can be able to see, even if you have changed the prevalence in the previous year, you can still continue for the consecutive 3 or 4 years ahead, so that you make sure that gain is obtained and sustainable. So that could I could just get there, and JP can add there in terms of modeling in that aspect.
Yes, the only thing I can complement, in fact, it's a permanent program, and the children go spontaneously out of the program. They go to school, primary school, they are involved in IPTSC, and when they leave primary school, they leave the program. So if the program then can be extended to older ages, that's future, that's hypothetical, but the children will then receive 5 years IPTSC and be protected and thrive and will have better school results and diminish the transmission. And at the age of 12, they leave school and then they leave the program. The second suggestion you make, there's normally no rebound effect. That's what we measured up to now. Now, if you do it, of course, on the longer term, we will assess, but there is no rebound effect. It's only when you stop, it comes back to where it used to be. And the reservoir, the school children, of course, the main reservoir, but they are not the only people carrying parasites, also the adults and children under 5 and pregnant women. Everybody carries parasite, but it's the main reservoir and the main source of transmission that we know today. But it's not, if you eliminate it, if you would be able to eliminate it in children, you don't eliminate malaria as such, because you still have the other age groups and the rest of the population. But it has a major impact for all. Over.
Thank you.
Thank you very much for answering this question and the questions before. I'm afraid we're out of time. It's noon already, so it's time to say goodbye. But based on the reactions, I think yeah, you triggered something with showing your presentation, and it opened up a discussion which we found very valuable. So allow me to thank everyone for attending this community talk. Thank you for your attention and for your participation. We believe it's very beneficial to share experiences and insights. But of course, also special thanks for the speakers, Dr. Geoffrey Makenga, Professor Jean-Pierre van Geertruiden, and Dr. Abela Lusasi for this insightful presentation and discussion. Again, this project is a good example of how to involve key stakeholders at the core of the project and how to translate research into policy and practice. So congratulations with the accomplishments, and we look forward to the continuation of your projects. And allow me also to already welcome you for the next community talk that will take place on July 31st. There we will cover food insecurity and abundance, and we'll have a look into sustainable food system. So a very different topic, but also quite promising. So stay tuned, check our website and our social media, as this project will also be, or this recording will also be shared on our website. So thank you very much, everyone. Have a lovely afternoon and see you next month.
Thank you. Thank you for hosting. Bye-bye.